assessment, choosing the response that best describes the patient more than 50% of the time during that visit. Direct observation, supplemented by interview, is the best way to complete these OASIS items. It should be noted that MOO 780 excludes injectable and IV meds and is the patient's ability to manage oral meds, not their compliance or willingness. MOO 800, management of injectable meds, excludes IV meds. MOO 810 and MOO 820, the OASIS items involved with the management of equipment by the patient and caregivers, includes only oxygen, IV infusion therapy, and enteral or parenteral nutrition equipment or supplies. Again, these questions relate to ability, not willingness or compliance. MOO 825, therapy needed, addresses the anticipated outcome of the full patient assessment as it relates to the need for PT, OT, and/or SLP. It determines whether or not the patient's care plan indicates a need for high therapy use, 10 or more therapy visits in the episode of care. Other OASIS items collected prior to or during the visit, not specific to physical assessment, are clinical record items and patient identification items, MOO 010 to MOO 100, demographics and patient history, MOO 140 to MOO 290, living arrangements, MOO 300 to MOO 340, supportive assistance, MOO 350 to MOO 380, therapy need, MOO 825, emergent care, MOO 830 to MOO 855, and discharge disposition information, MOO 870 to MOO 906. Assess for edema. Assess for any history of arthritis, gout, joint pain, swelling, or stiffness. Assess for weakness, muscle strength, the presence of an amputation or prosthesis. Observe the legs, including extremity temperatures and deformities. In many states, pain is now considered to be the fifth vital sign and is a required component of the patient's assessment. If a catheter is present, either a Foley or suprapubic, document the date of the last change, the catheter size, and balloon size. In addition, the GU system includes an assessment of gender-specific issues. For males, assess for prostate problems and sexual dysfunction. For females, assess for any history of hysterectomy or dysmenorrhea, the date of her last Pap test, any contraception use, and any estrogen replacement therapy that may be used. Ascertain the woman's pregnancy history, including gravida and para. For both males and females, assess for any sexual functioning issues as appropriate, and sexually transmitted disease symptoms. The clinician should determine the date of the last bowel movement, frequency of bowel movements, whether there is a feeding tube or ostomy. If there is, the date of surgery, type of appliance, and site, and who cares for it should be documented. Assess for indigestion, nausea, vomiting, ulcers, flatulence, distension, pain, hernia, diarrhea or constipation, rectal bleeding, hemorrhoids, gallbladder, gallstones, and jaundice. OASIS items MOO 540, bowel incontinence frequency, identifies only the frequency of incontinence, not treatment or constipation. MOO 550, ostomy for bowel elimination, identifies whether the patient has an ostomy for bowel elimination and whether it is related to a recent inpatient stay or a change in medical treatment. The neuro-emotional behavioral status of the patient is assessed to identify those mental processes or thoughts that may interfere with the individual's ability to reach optimal level of functioning. Observation of the patient throughout the assessment process, as well as interview strategies and data collection from the patient and patient's family, medical team, and health history, all contribute to the assessment process. The functional assessment is meant to be a combination of interview, observation, and direct practice of skills. Patients frequently overestimate their ability to do ADLs. Direct observation of these activities are the best way to assess the patient's ability to perform ADLs and IADLs, and leads to greater inter-rater reliability of assessments when done by clinicians of different disciplines.